Welcome, everybody. We're going to get started in just a minute. My name is Catherine Lontock, and I'm going to be your moderator today. I am the Director of Science and Policy Communications at IDF. So in just a moment, Dr. Antoine Azar is going to be presenting on PI and respiratory health. We have 45 minutes allotted for this session, and we do have to be strict about time. So if time permits, we will take questions at the end of the presentation. I do want to thank our generous sponsors for their support of our educational programming and community services. This particular session is supported by ADMA Biologics. A couple of disclaimers before we get started. Please note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or another qualified health provider with questions concerning a medical condition. The Immune Deficiency Foundation education events offer a wide array of educational presentations, including presentations developed by healthcare and life management professionals invited to serve as presenters. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of the Foundation. With that, I'm going to briefly introduce our speaker. His full bio is available in the app if you are interested in looking at that. So Dr. Azar is the Interim Director for the Division of Allergy and Clinical Immunology and Director for the Adult Primary Immunodeficiency Center at Johns Hopkins University. He completed his residency and fellowship training at the University of Iowa, where he remained on faculty, then moved to Johns Hopkins University, where he established the Adult Primary Immunodeficiency Center. Along with collaborators in pulmonary medicine, he has spearheaded the discovery of the association of COPD exacerbations and antibody deficiency. Welcome, Dr. Azar, and thank you for joining us.
Thank you very much. Thank you for the intro. Very glad to be here. Thank you to the IDF for all the work that you do. Thank you for inviting me to be here and to have this opportunity to speak. And what a wonderful session it's been this morning, and hearing stories from everybody who's gone through the PI journey. So what I'm going to be talking about is PI and respiratory health, and we will have enough time for questions at the end, so it's not going to be a full talk, just a brief one with some time if you have questions at the end. As you know, primary immunodeficiency includes a variety of multiple disorders, right? There's a variety of disorders under this big umbrella. The most common by far are what's called the predominantly antibody deficiency disorders, okay? However, there's many other disorders, combined immunodeficiencies, deficiency that can affect T cells or neutrophils like chronic granulomatous disease, immune dysregulation, complement deficiencies. But I'll focus more in my talk on these most common antibody deficiency disorders. And this is an overview summary, if you want, what the antibody deficiency disorders are. The B cells start in the bone marrow with the stem cell. The stem cell that gives rise to all the immune cells in the body. The stem cell gives rise to a pre-B cell. Then the pre-B cell leaves the bone marrow, goes to the periphery as a mature B cell. And this mature B cell initially produces IgM, which is the earliest antibody, IgM, immunoglobulin M. And when the B cell is activated, when it's stimulated by certain bacteria or virus or antigen, it will switch to produce IgG and IgA, and that's what we call the class switching. I think it's important to know what that is so we understand what all the antibody deficiency syndromes are. People who are born without Bruton tyrosine kinase, or BTK, they have X-linked or Bruton's agammaglobulinemia. These are kids who are born with no B cells at all, and therefore they cannot make any immunoglobulins, right? They don't have any immunoglobulins. They need to be on immunoglobulin replacement therapy forever. People with selective IgA deficiency, they have normal B cells, normal immunoglobulins, IgA, IgM is good. The only problem is they don't have IgA. And it's not a low IgA, it's an undetectable IgA, which typically in the lab, it's less than 5 or 7 milligram per deciliter, an undetectable level of IgA. People with the hyper-IgM syndrome, their B cells produce IgM, but this IgM cannot switch. They cannot do this class switching to make IgG and IgA. So they have a lot of IgM, but they have very little IgG and IgA. Patients with common variable immunodeficiency, which we'll talk about a little bit more, or CVID, they can have normal B cells or low B cells, but they cannot make enough IgG. So the IgG is consistently low, and very often IgA or IgM are low as well. And patients with specific antibody deficiency, which can be often missed because the immunoglobulins look normal. The B cells look normal, the IgG, AM, everything looks normal. However, these B cells don't work. So when you stimulate them with antigen, when you give a vaccine and you see how well people respond to vaccine, and the typical one we do is the pneumonia vaccine, they don't make antibodies in response to that vaccine. So they have normal levels, a normal size of the immune army, if you want, but the army is not fighting well, does not function well, and this is what we call specific antibody deficiency. This is just a brief overview of the antibody deficiencies. The most common symptomatic primary immune deficiency is CVID, which affects approximately 1 in 25,000 individuals, though we believe this is more than that. And it's defined by a low serum IgG, a low IgA or IgM or both, and poor production of antibodies, again assessed by a vaccine response. And you have to exclude other causes that can be causing this low IgG, like medications or losing immunoglobulins somewhere. Now, this data is from the IDF, and I want to emphasize that CVID and primary immunodeficiency disorders in general are not only diseases of infants and young children. I see primarily adults, and sometimes these are often missed because people have a misconception, oh, you cannot be in your 30s or 50s or 60s and have a primary immunodeficiency, right? More than half of patients living with primary immunodeficiency are adult patients. And this is data on the left from the European Society, on the right from the Mount Sinai group, again to show you at what age patients were diagnosed. You can be of any age and be diagnosed with CVID. You can be 80 and be diagnosed with CVID. So I think it's important to remember that these disorders can be diagnosed at any age. I have patients who have had illnesses and recurrent respiratory infections for years and years, and sometimes their physicians say, no, there's no way you have a weak immune system or primary immune deficiency, you're in your 60s. And then I have one of my patients, his wife kept looking and researching for like 2 or 3 years and finally found on the IDF website that, 2 or more pneumonias and recurrent bronchitis. She said if immunoglobulins checked, and she pushed the primary doc to get immunoglobulins checked, and they were all undetectable. No G, no A, no M. Okay? And these are the 10 warning signs that I'm sure you're familiar with about primary immunodeficiency in children. And there's a recent counterpart of that, the warning signs of primary immunodeficiency in adults as well. And as you can see, 2 or more new ear infections within a year, 2 or more new sinus infections within a year, 1 pneumonia per year for more than 1 year, which means that if somebody's had 2 documented pneumonias, that's already something that's unusual. Chronic diarrhea, recurrent viral infections, recurrent need for IV antibiotics to clear infections, deep abscesses, persistent thrush, and a family history of primary immunodeficiency. So the main manifestation of immunodeficiency that we think about are recurrent infections. However, there's a variety of other manifestations, and in fact, those other manifestations can sometimes be the presenting symptoms. These include autoimmune disease, malignancy, and inflammatory disease. Now, pulmonary disease, we're talking about pulmonary disease here in PI. And why is that important? Pulmonary disease is the most common cause of end organ damage in patients with immunodeficiency. And it often can be the initial manifestation of an immunodeficiency. I have several patients referred to me from pulmonologists because this is where the patients were coming to all the time with either inflammatory disease or recurrent infections. And there are certain features of the pulmonary manifestations that can trigger a diagnosis or trigger a workup for immunodeficiency disorders. That's why the pulmonary disease is really important in these patients. I'm going to talk about 3 broad categories of lung disease. I'm going to talk about recurrent infections, pneumonia and bronchitis. I'm going to talk about type of obstructive disease, bronchiectasis, and then about restrictive disease. I'll tell you about how these things are different, but as you can see, the top one is infection, The bottom two are not really infections or other types of inflammatory disease, all right? So not all lung disease is an infection. So what are the features of pulmonary infections? The key word here is unusual. Pulmonary infections of an unusual frequency, we just talked about having more than one pneumonia, is quite unusual, right? In somebody who's otherwise healthy. An unusual severity of infection, a pneumonia that's affecting multiple lobes, multiple parts of the lungs, a pneumonia that requires a very long time to heal and to recover, one course of antibiotics after the other, a pneumonia that requires patients to be in the hospital, in the ICU, or has complications that require surgical intervention or an abscess formation. And unusual organisms. If somebody has a pneumonia with pneumocystis or Pseudomonas, Aspergillus, CMV, these are unusual organisms that should not cause an infection in somebody with a normal immune system. And unusual complications from a pneumonia. Instead of having pneumonia, you get an X-ray, you get an antibiotic, and you're fine. A week later, this is one that ends up in empyema, which is infected fluid around the lungs, or a lung abscess, or so on. Now, whenever we look at recurrent pulmonary infections, we always got to keep our mind open. Not every recurrent pneumonia means an immune deficiency for sure. There are some other things we look for. Recurrent pneumonias that are always occurring in the same lobe, in the same part of the lungs, suggest that there may be a problem with that particular part of the lungs, like maybe an anatomical abnormality or an obstruction increasing the risk for pneumonia in that particular part of the lungs. Pneumonias that occur in dependent portions of the lungs always suggest that maybe there's some aspiration or reflux coming down to that dependent part of the lungs. And other things to think about on the differential of recurrent pneumonias that are often associated with sinus disease as well are cystic fibrosis and ciliary dyskinesia. So whenever you have a recurrent problems with pneumonias, all of these have to be considered on the differential. And that's why it's important with these pneumonias to be very clear as to where these pneumonias are. Are they always in the same spot? What did the X-ray show? What does CT scan show? Okay, let's move on to talk about bronchiectasis. I'm sure you're familiar or you heard this term or you may have bronchiectasis. The reason this is important is that bronchiectasis represents permanent lung damage that's usually caused by recurrent infections. So you have infection, certain parts of the lungs at the end causes this lung damage that's irreversible. And the more infections you have, the more you are at risk to develop this lung damage or bronchiectasis. Pulmonary function tests in bronchiectasis show that there's obstruction in the lungs. And the bronchiectasis can occur in multiple areas in the lungs, but typically we see those more in the right middle part of the lungs, more so than the lower lobe, and more so than the upper lobe. How do we detect bronchiectasis? A chest X-ray is great to look for a pneumonia, but it may be not sensitive enough to detect bronchiectasis. There may be sometimes the radiologist will see some increased markings around the bronchi, but that's not sufficient. The best way to look for bronchiectasis is a chest CT scan. That's the gold standard. And there are a number of findings that are typically seen in bronchiectasis that are recognized by the radiologist or by the physician ordering it. Dilated bronchi, it's called the signet ring sign, and a tree in bud pattern. And why is it important? Because sometimes we recommend for patients with CVID to get a CT chest as opposed to an X-ray and to try to screen for the presence of bronchiectasis. And why is that important? Is that treating bronchiectasis may need to be done more aggressively. Immunoglobulin levels may need to be higher in somebody with bronchiectasis. Remember, because you're going to try to really reduce the chance of recurrent infections and recurrent damage. And we often try to target a high level of trough IgG instead of 600 or 700, for example, maybe 1,000 or higher. This is a cohort of 900 patients with CVID, and this is just to show you that the number one manifestation, a third of these patients develop pneumonia. Then you have autoimmune disease, splenomegaly, and about a quarter of these patients did have bronchiectasis. There's another survey from 800 UK patients with CVID where about half of these patients had bronchiectasis. So again, that's an important thing to look for and to screen for. So another way to monitor for lung function, bronchiectasis, or other abnormalities of lung function is via pulmonary function tests. The nice thing about pulmonary function tests, unlike a CT scan, there's no radiation, right? It's a non-invasive test. Here on the left, you see one of my colleagues who's performing a pulmonary function test where you sit inside this chamber and you measure the flow, how much you can blow into a machine. There's something different or more minor procedure done frequently in the clinic called the spirometry. The spirometry is often done in the clinic. That's what you see on the right side. It's a little computer with a device. You blow into the machine, gives you how well your airflow is. That's a good, quick, easy test to do. However, the full pulmonary function test, which measure not only how well your flow is, but the volumes of your lungs and the diffusion capacity of your lungs, this is the better test that gives you much more information than the quick spirometry. And we often recommend doing this test first upon diagnosis to screen patients, and on a yearly basis, or if there's any signs of and symptoms of deterioration of lung function. It's an easy, non-invasive way to check for the lung function. We talked about bronchiectasis that we consider an obstructive disease. You often hear there's obstructive disease and restrictive disease, and what do these mean? So obstructive disease here on the left, you see the normal lung, and then what we mean by obstruction is the airways of the lungs, small airways, get smaller, right? You have these hoses that supply oxygen to lungs, and they get tighter and smaller. This is what we call obstructive disease, and this is what bronchiectasis manifests as. Now, restrictive disease, on the other hand, is when the lungs themselves, not the airways, the lungs themselves are affected by a certain inflammation or disease, and it will cause the lungs to shrink and to become less expansive, so they're more restricted in their movement. The pulmonary function tests that I just showed you are very good at differentiating between what's obstructive disease and restrictive disease, and also giving you a measurement of how much obstruction there is and how much restriction there is, because they measure the total lung volume, which is an indication of restriction, and they measure the flow, how good the flow is, which is a good measure of obstruction. This is a little bit of a busy slide, but I'm going to move on to talk about the third category, which is the interstitial lung disease that are seen in primary antibody deficiency. There's a whole list of disorders here that can affect the lungs, going from benign follicular bronchiolitis, which is just swelling of the lymph nodes that occur in the airways, and that's usually a benign condition, to lymphocytic interstitial pneumonia, which is a swelling of the lymph nodes or a lymphoid hyperplasia that is more of progression of the bronchiolitis, and you may have granulomas there as well. The nodular lymphoid hyperplasias are like almost lymph nodes, lymphoid follicles, that is considered to be a precursor to a lymphoma. There's non-necrotizing granulomas that are very commonly found in patients with CVID, not only in the lungs, but they can affect actually any organ. There's an organizing pneumonia, used to be called bronchiolitis obliterans and organizing pneumonia, or BOOP, now we call it organizing pneumonia. And there's GLILD, which is a broad term that stands for granulomatous lymphocytic interstitial lung disease. A very important manifestation of CVID, very important to recognize and treat. I'm going to be talking about it here shortly. These are the CT images of a 30-year-old a lady that I saw in my clinic, and she's at age 20. She had ITP, idiopathic thrombocytopenic purpura, low platelets, was treated, did well. Then a year or two later, she started to have recurrent bronchitis, one bronchitis after the other, for several years, and then these were getting worse, and then she was starting to have pneumonia. Then she ended up in the hospital with a pneumonia, and at some point her pulmonologist said, well, let's do a chest CT scan, and they found a lot of inflammation. That's what you see on the right side, and they eventually did the bronchoscopy, and they found a lot of bacteria, and they treated it, and then she saw another pulmonologist, and then a third pulmonologist. Finally, the third pulmonologist looked at that biopsy. He said, we're seeing here granulomas and lymphocytes. This looks like granulomatous lymphocytic interstitial lung disease, and this is what we see in CVID. So let's check her immunoglobulin levels, and they were all undetectable. So unfortunately, she's been going with this for a while, and I was able to find a previous CT chest from about 5-6 years ago, done for another reason, and you see the progression of disease that occurred over the past several years. So GLILD is a common cause of parenchymal lung disease or interstitial lung disease. And as the name implies, it's inflammation with lymphocytes and granulomas. People who have GLILD are also at an increased risk for autoimmune disease and malignancy. People who have GLILD often have frequent splenomegaly, lymphadenopathy, and liver disease. And these granulomas, not only can they occur in the lungs, but they can occur in other organ systems. They can occur on the skin, in the liver. I have some patients who have these lesions in the brain. So I think it's important to, I stress it's important to recognize this disease in patients with CVID. GLID typically occurs in females more than males, around the age of 20 to 50. It presents with gradual shortness of breath, cough, fatigue, and night sweats, but often it can also be asymptomatic. And that's why it's important to look for it and screen for it in patients with CVID. If progressive and left untreated, it can become really bad and lead to respiratory failure. On the CT scan, what you see is nodules primarily in the lower part of the lungs, some consolidation, and the nodules can be either solid or ground glass. And in addition to nodules, you see a lot of lymph nodes. And the diagnosis is made by obtaining a lung biopsy and by excluding other causes, because you want to make sure this inflammation in the lungs is not caused by an atypical infection or not caused by something else. I think it's important to make that distinction. One of the reasons it's important to make that distinction is the way we treat GLILD is with immunosuppression, right? So we are trying to suppress the immune system in somebody who's already immunocompromised. So in addition to making sure that the patient is fully supplemented with immunoglobulin replacement therapy, and like I mentioned earlier, even at higher levels and higher doses, the treatment of GLILD includes either steroids, which can be for several months or longer, or a combination of agents such as rituximab, azathioprine, mycophenolate, and there's a variety of other agents that have been used also for the treatment of GLILD. And depending on certain genetic causes of CVID, there are some more targeted therapy for GLILD. So patients are going to be on a combination of immunoglobulin therapy, but also suppressing this excessive inflammation in the lungs. I'll mention a couple of words on sinus disease. I know this is about respiratory health, but we cannot talk about respiratory health without sinus disease. The areas are all connected from the sinuses all the way to the lungs. And if the sinuses are not well taken care of and treated, then it's going to be more difficult to treat the lungs. So briefly, the sinuses are these empty cavities, and they're a perfect place for bacteria to come and sit in somebody who has a weak immune system. What's very important in these sinuses are these little hairs or cilia that are beating all the time and clearing the mucus all the time. But if these are not working well, if there's recurrent infections and recurrent damage, then you end up having a lot of chronic inflammation. And here you see on the left side, this is a patient who had, these are the maxillary sinuses right under the eyes that were completely full with inflammation, and they did much better after treatment. This is one of the findings you see on the CT, and the CT scan is the best X-ray or best imaging to diagnose chronic sinus disease. And typically what you see in chronic sinus inflammation is called an air fluid level, where you have fluid here indicating infection in the sinus. We looked at how common sinus disease in patients with CVID, and it's very common, depending on the studies, up to 90%, whether CVID or specific antibody deficiency. And the long-term treatment of sinus disease starts with topical therapy, topical steroids and nasal saline rinses. And if not enough, we need prophylactic antibiotics if there's CVID, immunoglobulin replacement therapy, and treating the underlying primary immune deficiency. Okay, let's go over an overview of how we manage lung disease and primary immune deficiency. First of all, you want to stop any additional insult to the lungs, right? Smoking, vaping, any addition is critical that you don't cause any more damage to the lungs and you protect them. Regular exercise is great at strengthening the respiratory and the peripheral muscles. And we know from patients who have bronchiectasis or patients who have severe COPD who undergo pulmonary rehab, which consists of some aerobic exercise and muscle strengthening. That's very good for respiratory health. For patients who have bronchiectasis, using a flutter valve, such an a cappella device, are also very helpful at trying to clear this mucus out and preventing it from accumulating in the lungs. Preventing infections with vaccines is also key. The yearly influenza vaccine, the inactivated vaccine, right? The influenza shot. The pneumococcal vaccine, and there's a variety of types of pneumococcal vaccines. The COVID vaccine, the RSV vaccine, and I copied this from there's 2 RSV vaccines that became available just a little less than a year ago. And this is from the CDC website. Any adult age 60 and older may receive a single dose of RSV using shared decision-making between the provider and the patient, and it's a single dose. Unlike the flu shot, you don't need this every year, just one time you're done. And who are the highest risk patients to RSV? Those who have older adults, those with chronic heart or lung disease, adults with weakened immune systems, and adults living in nursing homes or long-term care. So adults with weakened immune systems, what we're talking about in this conference, are considered high risk for RSV. And these are people who end up with hospitalized in the ICU and with very bad infections with RSV. In addition to vaccinating the patient, household contacts should also be vaccinated per their regular vaccine schedule, but avoid some live vaccines, right? Such as live influenza, polio, or smallpox vaccines. Then the next step in treatment is as needed antibiotics for respiratory infections, and usually treat early on and maybe treat for a longer duration of time in somebody with immune deficiency. We often use prophylactic antibiotics, and these can be done during the winter season, for example, if most of the respiratory infections are in the winter, or year-round, if respiratory infections are year-round, and immunoglobulin replacement therapy either intravenously or subcutaneously. And there's several other talks during the session during this conference on immunoglobulin therapy. A couple of data points I want to mention to you about immunoglobulin therapy, and this is a series of studies that looked at the prevalence of pneumonia in patients receiving immunoglobulin therapy. And what this shows you is with every 100 milligram per deciliter increase in the IgG trough level, there was a 27% decrease in pneumonia. So sometimes if your IgG level is around 600 or 700 or 800, looks like it's a normal IgG. But if somebody's still having recurrent respiratory infections and recurrent pneumonias despite a good IgG level, it means that they may need a higher dose of immunoglobulin therapy. And on a related note, these are a couple of examples. On the left side, they looked at a number of patients, and they looked at what level of IgG resulted in good clinical improvement. And patients had different IgG level, what's called their own biological level, at which they did well. For example, this patient here on the left, every time the IgG level went below 900, they started to have sinus infection and pneumonia. But above 900, they did great. Some other patients do very well with an IgG level of 600. And if you see on the right side, this is also another study looking at the mean trough IgG level that kept patients infection-free. And there's a wide range of levels. Yeah, in red, it's CVID, in blue, it's X-linked agammaglobulinemia. But some patients do very well in general on a level of 700, 800, 900. But if somebody comes to me with an IgG level of 900, but they're still having recurrent pneumonias and recurrent respiratory infections, then they may need a higher dose of immunoglobulin therapy. Okay, to sum up, take-home points. Pulmonary disease is one of the most common manifestations of PI and can be the presenting finding of a primary immune deficiency. Pulmonary manifestations include infections, bronchiectasis, and interstitial lung disease such as GI-LD. Recognizing early signs of pulmonary disease and primary immune deficiency is essential for an early diagnosis and treatment, and improving the long-term mortality and morbidity, and preventing and reducing the progression of lung disease. And I didn't talk about this. If we have time, I have a couple of slides, we can talk about it later. We've done a lot of work on patients with frequent COPD exacerbations, and we found that those with frequent COPD exacerbations could have an underlying antibody deficiency. That's an important phenotype to recognize. It's 11:45. We can pause, take questions, and if we have time, we can talk about that later.
Thank you so much, Dr. Azar. Okay, I'm going to skip through this, and hopefully we can get to it at the end. There we go. Okay, so before we open up for Q&A, just want to point out a couple of resources. And we've got the QR codes up here. You can just, use your phone, and it'll take you right to those resources. So we have Ask IDF. I like to say that it is our online hotline. If you have any question related to PI, you can submit it to Ask IDF, and we will either answer it, find you a resource, or point you in the right direction. I will say we cannot provide medical advice, right? Just like we can't here at today's, at the conference. If you need peer support, we have a great network of Get Connected groups. Some of them are based around particular diagnoses. A lot of them are actually geographically based, so even though they meet virtually, it's, the Mid-Atlantic region, for example. So these are great places to meet others that are sort of in your area and exchange advice, talk about, just living with PI. I also want to urge everyone to please complete your session survey in the app. This is how we know whether we're meeting your needs or not. So it's very important for us to hear from you. All right, so with that, we are going to open it up to questions. My lovely colleague has the microphone. Before we open for questions, though, I do want to just put a couple ground rules in place. Please keep your questions relevant to the topic of PI and respiratory illness. And please do not include any personal health information. So please don't go into your IgG levels and health information that is not relevant to a broad audience. We also ask that you not name specific brands of medications or specific providers or healthcare institutions. All right, Colleen, we'll come to you.
All right, we'll start on this.
Hi, I just have a question of how do you talk to your primary care doctors to make them understand that when you have an immune deficiency, you need antibiotics?
Yes, and are you asking me how do I or how do you as a patient?
What would be the best?
So I think first, we've gone a long ways in understanding and educating specialists outside of immunology about primary immune deficiency. A lot of it thanks to the IDF and the works of the past several decades. So I think educating the physicians, both primary care physicians or other specialist pulmonologists, ENT physicians, we're not where we want to be yet, but I think educating everybody else on these disorders is very important because a lot of, as you know, there's not many immunologists in the country, let alone adult immunologists, right? So I think as we educate physicians more and more, or providers more and more about PI, the same way we've done with diabetes or with cancer screening or heart disease or so on, I think that would be very helpful for all providers to understand that. And then communication between the physicians, the primary care, and the immunologist, communication between you as a patient and your primary care physician. And sometimes I've had a lot of my patients who gave some information to their primary, like, this is what I have. This is a couple of, go to the IDF website, print that chapter, this 3-4 page chapter on CVID, this is, and a lot of docs were very open to receiving that information and learning more about it.
Thank you. And just to let everybody know, tomorrow morning there will be a session pertaining to that very scenario. So I encourage you to come and join us.
In regards to the RSV vaccine, how important is it for us to have that vaccine, and have you found success in getting providers and insurance companies to cover it?
Yeah, good question. So, for the question about the RSV vaccine, so currently there's two RSV vaccines that are recommended for patients age 60 and older. All right. The vaccines seem to be, based on the studies, they seem to be decently effective. Maybe they reported 85% efficacy. However, the problem is a lot of these studies were not done on patients with primary immunodeficiency. In fact, patients with primary immunodeficiency were excluded from these studies. There's some studies that are evaluating the RSV vaccine in patients who are immunocompromised, and not only patients who are 60 years of older, patients who are younger than 60 who are immunocompromised. So I think my recommendation is, based on the CDC guidelines, that anyone 60 or older, I recommend it to all my patients to get the RSV vaccine. And it's much easier than an annual flu shot, because the RSV does not change every year like the flu, so it's just one vaccine only. In terms of data, how effective it is in reducing RSV in patients with primary immunodeficiency, we don't have that data. But I would guess that it would be less effective than what we see in studies about patients who have normal immune system.
Hi. If you have nodules that wax and wane on your lungs, could that be a sign of GLID, and can it obstruct some of your oxygen levels?
I'm sorry, I missed the first part. If you have...
I saw GLID. If you have nodules on your lungs, is that a symptom? And does it keep you from getting good oxygen to your lungs?
So if you have nodules, so there's a variety of types of nodules. There are like very benign nodules that a lot of people, if they do a CT scan, they're going to have like a tiny little nodule that's very small, and that's it. That alone would not typically be a sign of GLID. But when you have multiple nodules and infiltrates and lymph nodes in the mediastinum and around the lungs, these can be a sign of GLID. So it depends really on what the CT scan is showing, which this has to be done via a CT scan. What the CT scan is showing, one tiny little nodule that's small in size, that alone is not an indication of GLID, but there's a variety of other findings on the chest CT.
I have a question about nebulizing in addition to using a flutter valve and general exercise to deal with bronchiectasis and preventing infection. My specific question is about the use of a good pharmaceutical grade colloidal silver, as far as if you're trying to not be on prophylactic antibiotics, repeated pneumonias, et cetera, is there any, do you know of any benefit between just using saline versus occasionally, if you have an active or ongoing infection, to use something like a quality colloidal silver as well?
And if you could please speak up just a little bit. We can't hear you back here. Thank you.
Okay, is it better? Okay. I don't have information myself on colloidal silver. It's not something that I have used. Some other nebulizers that are helpful in patients with bronchiectasis, hypertonic saline nebulizers can be helpful, and that can be one of the things that can help clear the secretions. In somebody with chronic bronchiectasis who are colonized with certain bacteria, often if you have had bronchiectasis for a while, you end up having colonization with some bacteria like Pseudomonas, which is very sticky and very difficult to get rid of, and very difficult to just eliminate with antibiotics, and there's not many antibiotics that work against it. In those situations, you get an inhaled antibiotic that targets Pseudomonas, for example, tobramycin. I have a lot of patients who use this inhaled antibiotic. They use it typically 1 month off, 1 month on, to try to reduce that Pseudomonas burden, and can be quite effective. So there are some nebulized medications, especially antibiotics, that can help, but that depends if you're finding those specific bacteria, and that may be a way to avoid the use of oral or systemic antibiotics and avoid building resistance.
Hi, thank you. I have a question regarding bronchiectasis as well. If you do get it under control, is that something that can heal, or is that just you have your symptoms abated to some degree, but you still have bronchiectasis. There seems to be some confusion on that.
Yeah. So when you have bronchiectasis indicates a damage to this very tiny airways at the end of that bronchial tree. When you have bronchiectasis, when these airways become inflamed and dilated and scarred, that process is irreversible. So usually, most of the time, once you have documented bronchiectasis that you see on CT scan, this doesn't go back to normal, doesn't resolve, okay? However, you can prevent it from getting worse and progressing, because with every respiratory infection, and I think I had a slide somewhere that we didn't show, with every hit to your lung, with every respiratory infection, whether it's a respiratory viral infection with one of the viruses or a bacterial infection, there's going to be another hit and another risk of damaging the lungs. So you could have bronchiectasis and be aggressive with treating it, treat the underlying immunodeficiency, use bronchodilators, inhalers, and so on to stop it where it is at right now. So it doesn't go away. However, the symptoms can be very well controlled. So you can have bronchiectasis that you see, and once you treat it and you get things under control, some patients may do very well and not be symptomatic. But it's important to identify in order to reduce the risk that will get worse over time. There's a couple. No? Yes?
All right, so we're going to close out the session. I know that there are several more hands. Please submit those questions to Ask IDF, and you will get an email from us and more information. Thank you so much for coming to this session. Thank you to Dr. Azar. And enjoy the rest of the conference.